Hello, I'm Dr. Rafi Romano. This third movie will discuss the indirect simplified technique. Probably one of the most important parts in this bracket system in lingual orthodontics in general is how we place the bracket. What will be our learning objective in this in this specific movie? First of all, we will learn how to accurately place a bracket on the tooth. Second, we will learn the indirect bonding technique, how to bond the bracket on the desired place, and then we will learn how to make the transfer tray in order to transfer it from the model into the mouth. We want to vision our end result. Now, before we get into the bonding, we have to analyze the case. We have to look at the smile, at the height of the gingiva, how much the incisal edges are has attrition or abraded. Do we plan to restore them or we plan to cut them? This is a very important decision that will influence where we want to put our brackets. More gingivally, more incisally, more right, more left. We have space here. We want to close the space. By closing the space, we may get some tilting of the teeth. We may want to put in the brackets placement some overcorrection for this tipping. All these has to be taken into account when we will put the brackets on the model. You can see here that this patient that was bonded with joy bracket has a very deep bite. Now this deep bite, will it affect the peeling force on the bracket, which will cause debonding? Will it affect the opening of the posterior segment because of the lingual bracket? You can see here how much attrition he has in the lower incisors because of the deep bite. You can see the different gum level and the different incisor level and the two planes of occlusion. Now, in adult patient like him, do we plan to change the whole occlusion? And then we will go for maybe CAD/CAM technology, maybe for 3D control bracket like the Evolution? Or do we plan to do a very minor alignment before he will do some full mouth restoration? This is a very important question to be asked before putting the brackets. Now, I always look also at the X-ray records, panoramic, periapical photos, and sometimes cephalometric, because we want to make sure that if we want to upright the tooth, we do not look at the incisal edges which are abraded, we look at the angle of the root in order to place the bracket correctly. Now you can see what happened to this patient after we put a joy bracket. Look at the posterior, look at the anterior, and see here the contact between the lower teeth and the bracket. Because the joy bracket are so small and comfortable, he had very, very minimum interference from the brackets on the occlusion, but he had some bite opening from the back because of these brackets. So we had to support it and to plan it in advance with composite on the posterior area in order to give some relaxation to the mastication muscles. Here you can see the patient with the joy bracket in the mouth. That's another patient that we bonded joy bracket. We will discuss her in details in the case presentation lecture. Now, in such case like her, we need again to decide, do we want to upright the tooth completely? Do we plan to solve this crowding by stripping, by proclination, or by distalization? Now, when we do proclination, Obviously, teeth will become shorter because they go forward, and we will have tendency for open bite in the front. All this has to be taken into account, especially in the restoration part when we will want to restore the incisal edges. We will discuss it in details in the case presentation lecture. Again, I compare her clinical photos with her x-rays in order to locate the brackets where I want. You can see here in the upper right anterior central incisors, you can see that the bracket, we could put the bracket in the middle long axis of the tooth because of its size. If I would have used a wider bracket like some companies has, I wouldn't be able to put it so distally and in the middle of the tooth like I could do with a joy bracket. Now, we'll go to the next stage of learning how to do this indirect bonding on a plaster model. These are the tools we are using. We have a plaster model, which I'm sure all of you have in your clinic. We use some liquid, which is a separation liquid that we put on the teeth in order to isolate the plaster from the composite. Otherwise, we will not be able to prepare the tray. We have a pincette, we have explorer, we have light cure, we have a gauge to measure the height. We have some bonding paste. I use the Transbond, but you can use every bonding paste that you used to. We have light cure and we have a pencil. And of course, we have our Joy bracket kit. Now let's go to a movie that will show you step by step what we are doing. The first step is to take the plaster model and mark the long axis of every tooth. Now, when we mark the long axis, we have to put in our mind where we want this tooth to be. If we need to do some upright of the tooth, I may put in the long axis already this correction. And this will help me to get the alignment more quickly and more predictably. Now, I go tooth by tooth. I have the time to look at the model from different angles. When we do it indirectly, it has a lot of advantages over doing it directly in the mouth. I have the time. I don't have anybody waiting in my waiting room. I can do it tooth by tooth, slowly and accurately on every tooth. Now, after I finish the long axis, I will mark the horizontal line, which is the place where I will want to locate the bracket. This line is determined both by size of the crown, by the occlusion, and by the shape of the gingiva. When I have a very proliferated type of gingiva, I will try to locate the bracket away from the gingiva. When I want to have a minimum movement of teeth and more control and to get more close to the center of resistance of the tooth, I will try to locate the bracket more gingivally. And you can see here we do it one by one on all the teeth. Here you can see, you can compare this cross that we got for all the teeth. Now we repeat the same for the lower arch, the mandible. The teeth here are more, they are narrower, so we have to be more careful where we put the line, how we put the horizontal and the vertical line to see that we can actually locate the bracket inside this cross. Here you can see the lower arch is ready for bonding. Now I use the gauge in order to make sure that I have the same height from the incisal edges to the horizontal line that I marked, so I will not have an up and down difference between the teeth once I place the wire. So I go one by one, I check, and if I need, I change this horizontal line. Now we take a joy bracket outside of the kit. We put some paste on the base, and then we locate the bracket exactly on the cross. Now my assistant placed these brackets for me. She put it on the cross and without curing them. So I have still the option to go later on and check every bracket, change it according to my clinical preferences, and only then do the light cure. She cleans with Explorer or the remnants of the composite, so I will not have flashes when I will do the bonding. Now she handed me out the model. I check each one of the brackets. I change if necessary. All this is done before we do the curing of the brackets. After I have completed, she goes with Explorer and makes sure that all the sides of the brackets are clean. We don't have any remnants of bonding. And then we do the light cure. The light cure is done like it is done in the mouth. 20 seconds for every tooth, slowly, very carefully. Of course, it is more easy than doing it in the mouth because we don't have saliva and no problem. Now we prepare the tray. I'm using a transparent material named Memosil. There are many different materials. You put with a syringe, you put all the materials all around the teeth, buccal and lingual, and then you wet your wire with water, just simple water with soap, and then we just slowly with the hand, we do the shape of the tray. You wet your hand again and again, simple water with soap, and you can see how my assistant is designing the tray slowly, slowly. Make sure that the Memosil enter behind and above all the brackets. Then we let it stay for an hour just to cure nicely. You can do it even half an hour. Then with the scalpel, she cuts the tray nicely, lingually, buccally, to make a very nice tray that we can deliver to the mouth. Usually you don't need to do any cuts to release the brackets because the joy brackets are very, very small and it will easily go outside of the model or outside of the mouth when you will bond it in the mouth. You can see here, buccally, with a nice cut, just a little under the gingival line of the teeth. And we get a very, very nice tray ready for bonding. Now we leave the tray with the model, with the plaster model, for around 1 hour inside water. I do it usually for overnight. I leave it for overnight. And here you can see we take out the tray out of the water after 1 hour or 1 day. And then slowly you can really easily look how easily it goes out of the model. And all the brackets are inside, ready for bonding. All this procedure is done in my clinic very accurately. You will see cases done with this technique, indirect bonding. The cost is nothing. It's only the cost of this material, which is very minimal. And the procedure is very, very accurate and very, very good for minimal teeth movement let's say, even moderate teeth movement, not the highest complicated one, but even moderate you can do with this indirect technique. In summary, what we have learned today, first of all, spend enough time on planning the position of the bracket before you touch the plaster model, and then when you take the plaster model, when designing the lines and place it accurately. Overcorrect severely rotated teeth. It will be easy for you to bond the bracket more mesially in a tooth you want to rotate, or more distally, so it will give you a more fast and predicted rotation movement. Use patient records such as photos and x-rays in order to plan your accurate placement. Thank you very much, and I'm going to see you in my next movies on the jaw bracket, specifically and lingual orthodontics in general. Bye-bye.